So then coming to the next important topic is acute diarrhea and the critically ill. So diarrhea is a common finding in critically ill patients, whatever the initial cause of admission to the ICU may be. The prevalence of diarrhea in the ICU population is between 14 to 21%. So a concise and standardized diagnostic approach to diarrhea is mandatory for appropriate management. So the problem with diarrhea in critically ill patients are it is associated with the increased discomfort in a conscious patient, associated with perianal skin damage. It consumes nursing time and increased use of linen and other consumables. Plus, it causes contamination of nearby wounds and or femoral catheters if are present. Then electrolyte loss and dehydration can occur. So this can be very detrimental in patients with hemodynamic instability on vasopressors. So diarrhea can be divided based on three criteria. One is the stool frequency, stool volume, and stool consistency. So stool frequency, passage of 3 or more liquid or unformed stools per day. That is based on the stool frequency. Based on the stool volume, more than 200 grams per day or 250 ml per day, important in patients on colostomies. Based on the stool consistency, unformed or watery stools, that is Bristol type 5 to 7. So based on the chronology, it can be acute, persistent, or chronic, where acute is less than 2 weeks, persistent is 2 to 4 weeks, and chronic is more than 4 weeks. And based on the severity, it can be mild diarrhea or severe diarrhea. So mild is without dehydration or electrolyte imbalances, whereas severe is presence of fluid loss, that is dehydration, and need for electrolyte replacement. So coming to the etiologies, it can be disease related. So non-specific like gut hypoperfusion or hypoalbuminemia. Specific causes can be there because of pancreatitis, inflammatory bowel disease, terminal ileal resection, and short bowel syndrome. Then it can be medication related. So medication related, it can present with antibiotic associated with colitis like C. difficile, antibiotic associated with without colitis, and use of hyperosmolar preparations like hypertonic or sorbitol containing medications like lactulose or Kayexalate, oral electrolyte solutions, especially potassium. Then feed related due to lactose intolerance or bacterial contamination, especially with blenderized feeds, and hyperosmotic feeds with low fiber formula. Then infectious causes like viral infections like norovirus, rotavirus, adenovirus, or CMV, bacterial like E. coli, Salmonella, Shigella, Campylobacter, Staph aureus, Bacillus cereus, or Vibrio cholerae, and protozoal, which is suspected in HIV positive patients like Entamoeba, Isospora, or Cryptosporidium. So the pathophysiological manifestation in critically ill patients, either they can be because of osmotic diarrhea, secretory diarrhea, or motor impairment. So osmotic diarrhea, it occurs due to reduced water absorption as a result of increased osmotically active non-absorbable molecules or a short passage time. So it is mainly seen with hyperosmotic medications, hyperosmolar enteral feeds, osmotic laxative abuse, or Whipple's disease. So it is seen as watery stools with an increased stool osmotic gap. Secretory diarrhea, on the contrary, occurs as a result of mucosal secretion of electrolytes and fluids into the interstitial lumen with or without decreased absorption. So it leads to watery and voluminous diarrhea. So it is seen due to increased gut permeability as in infections or inflammation, secretagogues, vasoactive intestinal peptides producing tumors, and gastrinomas, and non-osmotic laxatives. Non-impairment can occur due to decreased area of contact or gut hypermotility with decreased time of contact between the gut contact and the intestinal mucosa. That is seen in short bowel syndrome and diabetic neuropathy. So these are the three classifications and manifestations of diarrhea in critically ill patients. So the normal stool osmolarity is between 290 to 300. So stool osmolar gap is the measured osmolarity minus 2 into sodium plus potassium. So the range is between 50 to 100. If it is less than 50, it is secretory. If it is more than 100, it is osmotic. So the clinical features, If it is a non-infectious, non-inflammatory diarrhea, it is non-bloody, there is no fever, it is usually osmotic. So stool output predominantly with feeding, or it can be malabsorption associated with increased stool fat or foul smelling, especially in patients with pancreatitis who have been on long-term ICU stay because of the poor release of pancreatic enzymes. There can be malabsorption which can occur. So management of these patients would be with use of pancreatic enzymes. Whereas for infective or inflammatory, the stools with mucus or blood can be there, which can be infective or ischemic, with associated fever, abdominal pain plus or minus distension, and vomiting. So the diagnostic approach, you always need to go in a step-wise manner: history, examination, and testing. So history, first general history that you need is the onset in relation to hospitalization, the duration, the characteristics, whether it is bloody, watery, or postprandial, travel history, dietary history, and immunocompromised state. Then medical history, history of IBD, chronic pancreatitis, short bowel syndrome, hyperthyroidism, post-cholecystectomy status, or high osmolality diet with low fiber. If they are on any current medications like oral electrolyte solutions, lactulose, sorbitol containing medications, or antibiotics like erythromycin or azithromycin. Then in the physical examination, you need to assess the volume status, review the previous electrolytes, assess for perianal inflammation, see for fever, and if infectious diarrhea is present, then you need to look for also hemolytic uremic syndrome. Then diagnostic testing, you need to check the complete count, blood counts, check the albumin levels, electrolytes, and blood cultures if it is required. Then specific testing, you need to assess the stool routine, stool culture, and stool for ova and parasites, especially in immunocompromised cases. If there is more than 3 days of ICU stay with antibiotic exposure being there, then C. difficile workup needs to be done. So if there is bloody diarrhea after presence of shock, then ischemic colitis is another differential you need to keep in mind and consider CT for ischemia evaluation. So I had mentioned about the stool osmotic gap where it is beneficial is in patients with persistent or chronic diarrhea. So if diarrhea is present with more than 3 days of ICU stay, first thing is you check if the fluid and electrolyte status is disturbed. If it is disturbed, you correct it, then you go ahead with further workup. Whereas if there is no disturbances, then you check whether it is patient is possibly infectious, immunocompromised, or there is presence of bloody diarrhea. So if it is present, then you need to work up further. If neither of them are present, then you don't need to work up further. So then once you see if there is infectious or immunocompromised or there is presence of dehydration with electrolyte imbalances, you assess for signs of infection. Temperature more than 38.5, bloody stools with fecal RBCs. If it is present, then you need to do a stool workup for C. difficile and specific pathogens according to the symptoms and immunosuppression state. So bacterial infections you need to consider are E. coli, Salmonella, Shigella, Campylobacter, Vibrio or Bacillus cereus, viral, rotavirus, adenovirus or CMV, and protozoal like Microspora, Isospora, Cryptosporium, and Strongyloids. So if the workup is positive for these pathogens, then you treat them accordingly. If workup is negative or if it is positive, then you evaluate for concomitant factors also, because many times that may be multifactorial. If there is no signs of infection, then you assess for risk factors exposure like antibiotic use, immunosuppression, and contaminated feeds. If these are there, then again you need to work up for C. difficile or other infective diarrhea. If neither of them are there, then it is probably non-infective. So then you assess for medical etiologies. So if there is chronic pancreatitis because of exocrine deficiency, then you need to give pancreatic enzymes. Whereas if it is endocrine, like diabetic autonomic neuropathies, hyperthyroidism, or Zollinger-Ellison syndrome, then you need to treat the triggering factor. So if there is intoxications like heavy metals, you need to decontaminate and chelate. For inflammatory bowel disease and short bowel syndrome, again, you need to treat the underlying precipitating factors and consider immunosuppression therapy. If none of these are there, you check the enteral formulation feeds if there is high osmolality, high fat, and no fiber. So if it is there, then you need to go with low osmolality, semi-elemental, or high fiber diets. If enteral nutrition formulas are not a problem, then you check the medications. So non-absorbed sugar-containing medications, hyperosmolar medications, or antibiotics if they are present. If they are there, optimize your medications. Change oral to IV whenever possible. If there is no problem in medications also, then you go with assessment for gut hypoperfusion. So based on that, you optimize your nutrition and monitor for bowel ischemia. So just for completion, mechanism of antibiotic-induced diarrhea without colitis because of a direct prokinetic effect of antibiotics on the GI motility, especially with erythromycin and azithromycin. Microbial modification of unmetabolized carbohydrates causing osmotic diarrhea. Unmetabolized dihydroxy bile acids due to the disturbed microbiota inducing secretory diarrheas. So these are the three important mechanisms of antibiotic-induced diarrhea without colitis. So once you've identified the etiology, you need to optimize and then observe in the ICU. So if no signs of infection are there, no is not immunocompromised, is not elderly with persistent diarrhea despite optimization, then you need to consider antidiarrheals. So the most important complication that's usually seen is perianal skin lesions and associated wound infection. So it is very, very important to avoid this. So whenever the patient passes stools, it is important to clean it as early as possible because the increased duration of contact of the stools with the skin can lead to inflammation. So next, coming to the very important topic, that is C. difficile. So C. difficile is one of the causative organisms of antibiotic-associated diarrhea. So it can manifest as C. diff-associated diarrhea, pseudomembranous colitis, and toxic megacolon. It is highly transmissible via fecal-oral route via ingestion of spores. The organisms can be cultured easily from the hospital environment, including hands, clothing, and stethoscope of healthcare workers. So the general risk factors are disruption of the indigenous microflora, mainly because of antibiotics like fluoroquinolones, clindamycin, cephalosporins, and carbapenems. Then cancer chemotherapeutics, pre-operative bowel preparation. Then opportunity for infections like prolonged hospital stay, microbial factors like toxigenicity and additions, and diminished gastrointestinal defenses like reduced or suppressed gastric acid secretion like use of PPIs, parenteral nutrition, and GI surgery. So prior risk factors associated are old age, cancer, CKD, bedridden state, and long-term use of corticosteroids. So coming to the microbiology, C. difficile is an anaerobic gram-positive spore-forming toxin-producing bacillus. So it exists in two forms. One is the spore form, which is outside the colon. It is resistant to heat, acid, and antibiotics. Whereas the vegetative form is when it is in the intestine, fully functional toxin producing form, and it is susceptible to killing by antimicrobial agents. So the toxins, C. difficile produces two toxins that mediate colitis and diarrhea by entering intracellularly via carbohydrate binding. So toxin A or enterotoxin causes inflammation leading to intestinal fluid secretion plus mucosal injury via release of chemokines and cytokines. That is arachidonic acid metabolites IL-1, IL-6, and TNF-alpha, leading to formation of pseudomembranes via neutrophil activation. So this is about toxin A. Toxin B is once intracellular, they disrupt the cellular pathways involving cytoskeletal structures and signal transduction, leading to disruption of tight junctions, leading to colonic mucosal damage and promoting shallow ulcers on the mucosal surface. So the important thing you need to keep in mind, pseudomembranes are associated with toxin A and mucosal surface ulcers are associated with toxin B. So coming to the pathogenesis for the first infection, antimicrobial therapy leads to disruption of colonic microflora. C. difficile exposure and colonization occurs, leading to release of toxin A and B. So that leads to mucosal surface injury and inflammation. So recurrent infection can be due to persistent spores from the initial infection or reinfection by exogenous C. difficile in association with an impairment of host response. So the clinical manifestations, we have a non-severe disease where there is watery stools, that is more than 3 stools in 24 hours, lower abdominal pain with cramping, low-grade fever, nausea, and vomiting. In absence of the above features, unexplained leukocytosis may reflect C. difficile infection in at-risk populations. Then you have something called recurrent disease. So recurrent C. diff is defined as resolution of C. diff symptoms while on appropriate therapy, followed by reappearance of symptoms within 2 to 8 weeks. So that is the timeline. Then you have severe colitis, that is diarrhea, lower abdominal pain with distension, fever, hypovolemia. Because of that hypovolemia, lactic acidosis is there. Then associated hypoalbuminemia, elevated creatinine, and mucocytosis. So the last four are lab parameters. The first four are clinical manifestations. Then you have fulminant colitis, that is severe colitis with the below findings, that is severe hypotension leading to multi-organ dysfunction and megacolon. More than 7 centimeter diameter in colon or more than 12 centimeters in the cecum. So four manifestations are there which can manifest: non-severe disease, recurrent disease, severe colitis, and fulminant colitis. So coming to the diagnosis for lab testing, you can go with nucleic acid amplification testing via PCR. It's a type of agnostic test that detects the genetic material in C. difficile. So it identifies the TED-B, which encodes for toxin B. It is a high sensitivity but low to moderate specificity. Then glutamine dehydrogenase via enzyme immunoassay. So it detects the highly conserved metabolic enzyme present in all levels or in high levels in all isolates of C. difficile. The advantage is it is usually available in 1 hour. However, since it is present in both toxigenic and non-toxigenic strains, GDH lacks specificity. So the important thing is it needs to be combined with another test. Then C. diff toxin AB via enzyme immunoassay. It has moderate sensitivity but high specificity. So the problem is there are chances of high false negativity as 100 to 1000 picogram of toxin must be present for the test to be positive. So now the recommendation for diagnosis, usually they go with assessment of toxin A and B, and along with that they also check the GDH levels because that helps in better identification. Then selective anaerobic cultures via rectal swab specimen detects vegetative cells and spores. It is highly sensitive but takes several days to finalize, not routinely recommended for clinical use. Then cells culture cytotoxic assay detects the toxins directly in stools, begins with preparation of stool filtrate which is added to a monolayer of an appropriate cell line. Following incubation, the cells are observed for a cytopathic effect. It has a good sensitivity and specificity, however, it is time consuming and labor intensive and not routinely practiced. So for C. diff workup, you send stool for GDH and toxin AB. So if GDH is positive, toxin is positive, testing consistent with C. diff. Whereas if GDH is negative and toxin is negative, it is not consistent with GDH. With C. difficile. Whereas if one is positive and other is negative, then it is an indeterminate result. Then you do a NAT. If NAT is positive, consistent with C. diff. If NAT is negative, it is not consistent with C. diff. So the important differentials you need to keep in mind are acute colonic pseudo-obstruction, other antibiotic-associated diarrhea with colitis like Staph aureus, Klebsiella oxytoca, or Clostridium perfringens. Non-infectious like inflammatory bowel disease or celiac disease, and enteral feed-related bacterial contamination. So for diagnosis, radiographic imaging, CT imaging on the abdomen and pelvis with oral and IV contrast is the preferred modality. So plain X-rays may be useful in circumstances where CT is not readily available. So colonic dilatation more than 7 centimeters in dilatation in the setting of CDA is diagnostic of a toxic megacolon. So the other findings that can be there are air fluid levels, thumb printing, bowel perforation. So rigid sigmoidoscopy is not warranted if the patients have typical features of C. difficile with positive lab test with or without clinical response to empirical therapy. It is recommended if alternative diagnosis is suspected that requires direct visualization with biopsy. In patients with ileus or fulminant colitis in the absence of diarrhea, in this situation, sigmoidoscopy can be done. So it helps in visualization of pseudomembranes. Biopsy per se is not needed for C. diff diagnosis. It is only warranted to establish an alternative diagnosis. So the general principles of treatment, number one, which you need to keep in mind when you answer is the infection control. So patients with suspected or proven C. diff should be managed with contact precautions. Healthcare workers should wash hands with soap and water rather than alcohol-based solutions before and after patient contact. The main reason for this, alcohol-based solutions are resistant to microbial spores. Then discontinuing inciting antibiotics and PPIs. If ongoing antibiotics are crucial for treatment of primary infection, it is prudent to select antibiotic agents that are less frequently implicated in C. diff associated infections. So treatment of the inciting antibiotics is associated with prolongation of diarrhea, increased likelihood of treatment failure, and increased risk of C. diff, recurrent C. diff. Then management of fluids, nutrition, and diarrhea. Correction of new fluid and electrolyte imbalance is very, very important. As diarrhea is due to colonic process, instituting measures or lactate-free diet is not needed. Anti-motility agents are only reserved for use in patients with fluid losses in the absence of ileus or colonic distension. So for specific management, non-severe illness, you can go with oral fidaxomicin 200 milligrams 12th hourly for 10 days or oral vancomycin 125 milligrams q 6th hourly for 10 days. Alternative agent, if both of them are not available, you can go with metronidazole. But the problem with this is it is associated with high recurrence rates. For severe illness, you can go with oral fidaxomicin plus oral vancomycin. So due to mucosal disruption, systemic absorption of oral vancomycin can occur. So it is important to monitor the trough levels of vancomycin, especially in patients with creatinine clearance less than 10 ml per minute. So there is no role for metronidazole in severe cases. In fulminant colitis, if there is no ileus, then you can go with oral or nasogastric vancomycin 500 6th hourly with metronidazole 500 8th hourly for 10 to 14 days. If ileus is present, then you can continue with this regimen plus go with rectal vancomycin 500 milligrams in 100 ml of 0.9 ns as retention enemas. And consider fecal transplant and or surgery. There is no role for fidaxomicin in fulminant cases. So coming to recurrences, the first recurrence, you can go with oral fidaxomicin for 200 milligrams BD for 10 days, then 200 milligrams OD on alternate days for 20 days. Or oral vancomycin as pulse tapered therapy. 125 6th hourly for 10 to 14 days, then 12th hourly for 7 days, 24 hourly for 7 days, then 48 hourly for 2 to 8 weeks. This either of this therapy, you need to add Beslotoxumab. Okay, so that is a map that is targeted against the toxin B. So there is no renal or hepatic dose modification, and you need to be very cautious in patients with congestive heart failure. So the dose is 10 milligrams per kg, and it is a map targeted against toxin B. So this is very, very important. So if there is a second recurrence which has occurred, then you need to go ahead with fecal transplant and also need to repeat Beslotoxumab. So indication for surgery is ileus, significant abdominal distension, peritonitis or significant abdominal tenderness, end organ failure, and failure to improve after 3 to 5 days of maximum medical treatment. So these are the main indications for surgery. So it is done as a subtotal colectomy plus residual stump, rectal stump plus terminal ileostomy. Subtotal colectomy, terminal ileostomy, and a residual rectal stump. So the last topic under this is fecal transplant. So the term microbiota refers to a community of microorganisms comprising of bacteria, viruses, and protozoa in a healthy human. So they influence GA motility, regular mucosal barrier function, epithelial cell turnover, influence immune responses, and suppress pathogen overgrowth. So dysbiosis can be seen due to artificial instrumentation of the upper airways and upper GA tract, host response to critical illness, which can lead to ischemic perfusion injury of GA tract, lack of luminal nutrients in the gut, which can cause catabolic starvation of bacteria, and medication like opioids, which can cause decrease in the intestinal motility, pH, which can alter the pH in stomach and alter the microbiota environment. So the principle of FMT is a procedure. It is a procedure during which minimally processed feces from the healthy donors are transferred into the patient's gut. So the donor microbiota is then engrafted into the recipient, and that increases the microbiota diversity. So restoring the normal bowel function in patients with dysbiosis associated diseases such as Clostridium difficile, IBD, and metabolic syndrome. So these are the three areas where FMT has been studied. So the indications, proven indication is in C. diff and potential role in inflammatory bowel disease, metabolic syndrome, and MODS in critically ill patients. So contraindications are known case of hepatitis B, C, or HIV, known exposure to HIV or hepatitis B in the last 12 months, antimicrobials in the preceding 3 months, major immunosuppression therapy, history of major GA surgery like gastric bypass or partial colectomy, underlying GA malignancy, history of IBD, connective tissue disorder, or metabolic syndrome. So the donor screening investigations are you need to look for CMV or Epstein-Barr, hepatitis A, B, C, E, LFT, syphilis workup, HIV 1 and 2, complete blood count with the differentials, inflammatory markers like CRP and ESR, albumin, urea, creatinine, and electrolytes. In the stool, you need to do a C. diff toxin PCR, fecal microscopy and culture and sensitivity to rule out pathogens, fecal cryptosporidium pathogen, norovirus or rotavirus PCR, and fecal occult blood testing. So the fecal preparation, fresh fecal material should be processed within 6 hours of donor production and stored at room temperature. About 50 grams of fecal matter is mixed with 150 ml of sterile sodium chloride via a blender. So it is filtered by a filter or gauze to clear the large particulate matter which may obstruct the endoscopic channel. Finally, the filtrate is infused into 60 ml syringes, generally 4 to 5 tubes, and then infused into the patient's GA tract. That is the recipient's GA tract. So this is the basic preparation process. So patient preparation and delivery, patient should not be administered any form of antibiotics 12 to 48 hours before the fecal infusion. Bowel should be free of contaminated fecal material prior to donor feces infusion to ensure healthy graft. So the delivery methods, upper GI, you can go with the OGD scopy or nasogastric or nasojejunal tube, and lower gastrointestinal either via colonoscopy or retention enemas. So the side effects are you have serious, minor, and potential. Serious are bleeding, complications of endoscopy like bleeding or perforation, adverse effects related to sedation like aspiration, transmission of enteric pathogens, pneumonia, and IBD flares. Minor complications can be there like abdominal discomfort, bloating, flatulence, diarrhea, constipation, nausea, vomiting with transient fever. And potential complications is transmission of unrecognized infectious agents that cause infections years later.